Hi, this is Dr. Renzo Cataldo. I work with Biltmore Cardiology, and I'm a cardiac electrophysiologist. Let's talk about atrial fibrillation, a little bit of the cardiac anatomy, and how we can prevent strokes with atrial fibrillation. So the heart has 4 chambers, 2 on the top, 2 on the bottom. The bottom chambers are the main pumping chambers of the heart. The top chambers don't do very much pumping, but they give rhythm to the heart. Normally speaking, there's an electrical signal that originates over here in the top right chamber of the heart, goes to the top left chamber of the heart, eventually makes its way down to the bottom chambers of the heart. With atrial fibrillation, the top chambers of the heart are not in a nice normal rhythm like this, right? But they're just kind of wiggling, right? And when they're wiggling like this, they're basically in chaos. And the bottom chambers of the heart don't know what to do with this chaos, and they tend to go rapidly and irregularly. One thing to really know about atrial fibrillation is that the heart is not smooth like the Valentine's Day heart, right? What we're born with are these little pouches that stick out in the front of the heart. If you're in normal rhythm, blood gets squeezed in and out of these pouches all the time. But if the top chambers of the heart are just kind of wiggling like this, blood has a tendency to stick around in those little pouches, and you can have a little blood clot forming in that little pouch. If that blood clot is stable and sits there in the top left chamber of the heart, it's not going to do anything to you. You're not going to know it's there. But if it travels, you will definitely know, because you can have a stroke or it can go elsewhere in your body and cause all kinds of problems. Generally speaking, some people are at higher risk and some people are not quite so much at higher risk for developing blood clots on the inside of their hearts. We sort of accumulate a certain medical baggage in our systems, right? That medical baggage tends to haunt us in our later years. There's sort of a scoring system that we go by that tells us, who am I looking at in terms of my patient, right? Is it someone who's young and relatively healthy, or am I looking at somebody who's a little bit not so young and not quite so healthy, right? There are certain things that will increase the risk of a stroke in the setting of atrial fibrillation. For example, people at 65 years of age are at somewhat of a higher risk. People at 75 years of age are at much higher risk, right, of developing a stroke. People with prior strokes, people with congestive heart failure, people with prior heart attacks, people with diabetes, people with high blood pressure. And finally, women more commonly have strokes than men in the setting of atrial fibrillation. So we kind of have to, in my mind, I have to do a little bit of mental math in terms of who am I looking at and what is the risk of this person's atrial fibrillation and the risk of stroke with atrial fibrillation. If somebody has a score that's intermediate or greater, in other words, a score of 2 or greater, the general recommendation is to be placed on a blood thinner, all right? And there are several blood thinners that are out there. Sometimes we recommend an aspirin alone to people who are relatively lower risk. Sometimes people just can't take these medications because they have a tendency to bleed elsewhere, like in their brain or in their nose or in their urine or in their bowels, all right? But other times people just can't afford it, or sometimes people are at risk of falling down. And if you fall down and you're on blood thinners, you're more likely to have serious consequences from that fall. There are lots of reasons why people cannot take blood thinners because of that little pouch over there. But what we can do is to occlude that pouch. There are 2 devices out in the market right now. Here is one of them. Here is that little pouch. And everybody's pouch is just a little bit different. Different people have different size pouches and different shaped pouches. It's almost like your thumbprint. This device is, one of them kind of looks like a little parachute, and it's got little anchors on it. Another one looks like a little hockey puck with a plate on it, and that's got little anchors on it as well. Pretty much the same implantation technique to implant this. People are placed under anesthesia. The anesthesiologist or a cardiologist can place a probe into the food pipe, get some very detailed pictures of that little pouch. It's called the left atrial appendage. And we can see, number 1, are there any blood clots in there? Number 2, how big is that? How deep is it? And what's the shape of it? A person such as myself would place a tube inside a vein in the crease of the leg, and then place that tube over into the top right chamber of the heart, and then cross over into the top left chamber of the heart and point this little tube towards that little pouch. These devices come in lots of different sizes, but essentially two shapes. And we would decide before the placement of this device, we could decide the size of this. And then we would place this device into the left atrial appendage. And then we deploy the little device into that pouch. Then we unscrew it, and then the device is permanently implanted there. We would have to institute a little bit of surveillance of that little device, either CAT scans or transesophageal echoes. In other words, an ultrasound picture of the heart taken from the food pipe. Eventually, we can take people off the blood thinners because these are people who usually are pretty high risk for taking long-term blood thinners in the first place. The chances of anything at all going wrong during this procedure are relatively small. We do lots and lots of these things. There's a small chance of just bruising, but very small chance also of complications at the groin insertion site. If that should happen, we may have to call a surgeon to fix that. We're talking about 1% or so. The chances of a catastrophe to happen, perforating the heart, or having this little device dislodge and go elsewhere inside your body, that turns into an emergency type of situation, but it's quite rare. Ultimately, we can take people off blood thinners because of the advent of these little left atrial appendage occlusion devices.